Thanks, Katie. Hello, everyone. It's very good to be with you this afternoon. I've done a few other projects with CHAMPS and so admire the work you all do. And of course, we have some of you that attend our national conference we were just talking about before the session started. And so it's really good. It's good to see the names pop up. It's good to be with you here today. As Katie mentioned, I'm with the National Healthcare for the Homeless Council. If you're not familiar with the council, I would encourage you to go to our website. You'll see that our web address is there at the end of my email address, nhchc.org. And you will find more resources about our topic today, as well as hundreds of other topics at our website, where we're really committed to all things at the intersection of healthcare and homelessness. So we have over 1,000 different resources there. They're free. We also, specifically around the topic of safety and security, we have a number of online courses around safety and security. And so if you go to our resources tab and look for our learning management platform, you do have to create an account, but it's free, and you'll be able to see all the courses that we offer there. And then my email address is there. I would encourage you, if you think of questions, or if you disagree, or if you think of ideas or something that would have to do with this course, please feel free to email me. I'm happy to kind of keep the conversation going, and we're happy to talk more about things that you may be looking at specifically at your health center. My background before coming to the council was primarily in direct services. I worked in a shelter, a couple of different shelters for several years with children, and it was a domestic violence shelter. And I worked in a detox unit and a substance use treatment center and a halfway house for women coming out of incarceration. And then I worked for a while at a health center for people without insurance, all here in Nashville, Tennessee. I'm about 30 minutes outside of downtown Nashville. So a lot of what we're going to talk about today is going to come out of my experience. But then the bulk of what we're going to talk about today is coming out of some listening sessions that we conducted coming out of the pandemic. We received we were looking at safety and security in 2019. Our administrators committee had asked us to do that. So we were beginning to do some research. All that, of course, was put on pause. But then coming out of the pandemic, we were seeing a lot of research that showed that there had been a significant rise, a huge rise in the number of reports, incident reports, reports of aggression or violence. The American Nurses Association did research on that. That we were just seeing a huge increase in the number of people who were working in health centers and really feeling like they were at risk. And there was research to back that up. And so we conducted over 20 listening sessions, interviews with people specifically working in healthcare for the homeless health centers. We talked to providers, we talked to administrators, we talked to security specialists, we talked to intake specialists and nurses. We talked to people at every level of care to really think about what helps you to feel safe, what doesn't. And then we also did a number of listening sessions with patients, patients who had experienced homelessness and received services at an HCH, and some amazing conversations. So a lot of what we're going to talk about today is going to come out of that as well. As I mentioned, I worked at a health center 10 years ago, 10 or 11, 12 years ago. We were a health center in close to downtown Nashville. We were specifically created to serve the needs of refugees and immigrants. We're a refugee hub here in Nashville. And so that was our primary population. We had over 60 languages spoken in the health center. But we also served patients who were not insured. And so that wasn't so people experiencing homelessness, that wasn't really our target population. And we didn't have a huge number of patients that were experiencing homelessness. And so it wasn't our expertise, but certainly it was a population that we had a lot of compassion for and wanted to learn more about. But ironically, right behind our building, there was an alley. It kind of connected our building and the building next to us. And in this alley, there lived a gentleman who was experiencing homelessness. He had lived in that alley for over a decade. And he had an intricate system of tarps. He had actually built some shelters out of some pallets. It was a very sustainable shelter that he built back there. He lived there year round. He had a fire pit. But it was clear, especially as time progressed, that he was not in good health, and he limped and he had a cough. And so some of our providers and really all of our staff at one time or another, it seemed like, made some effort to try to connect with him, and they would bring him water and blankets or food. They would just try to reach out to him, and he was not receptive to that at all. In fact, he made it very clear he really just wanted to be left alone. So it was really interesting that one day, after we had months and months and months of attempts to reach out to him, he walked into the clinic. He was the first one there at 8 o'clock one morning. And he looked very, very sick. His color, he was very pale. His lips there were a little tinge of blue around his lips. He was limping much more than he normally did. He had a horrible cough. He came to the desk and said he wanted to see a doctor, and he wouldn't provide any intake information. I think he gave a first name of something like William, and no medical history. He made it very clear he just wanted to see a doctor. So he was a little impatient, a little frustrated. I mean, he was clearly agitated. But we took him to an exam room, and we had a pretty small clinic and a pretty standard sort of pod format, where we had in the middle this nurses station with sort of a countertop desk that made a circle, and that's where the nurses and providers had their laptops, and there were desks in there, and that was the middle of the room. And then around the room were the exam rooms, and we had 12 exam rooms all around the room. So when you stepped out of an exam room, you were facing the center of the circle, you were facing the nurses station. So he was put into an exam room, and they began to do some tests and determined that he had double pneumonia. He was in renal failure. He had a urinary tract infection. He had some kidney issues. He was very, very sick. So they implored him, they begged him really to go to the hospital. They offered to drive him to the hospital. We offered to call an ambulance. And he said, if you try to take me to the hospital, I'm walking out the door. Give me some medicine. I'm spending the night right here tonight, and where I always do. So the providers were really perplexed. And at noon, we closed for lunch. We didn't see any patients from 12 to 1. At 12:15, all of the other patients were already checked out. Most of the providers were eating. There were a few nurses and a few students in the pod. And then, a provider or two trying to figure out what they were going to do. They were actually thinking about doing IV antibiotics there in the health center, which we never did. We didn't even have the equipment to do, just kind of a desperation of what are we going to do. And as people were standing around talking about it, all of a sudden the door to his exam room flew open, and a folding chair went flying out the door and slammed into the nurse's station and then crashed on the floor. And then he immediately emerged, and he was holding onto the door frame, and he was screaming. And he said, if someone doesn't give me something right now to make this pain go away, and he had all these threats, which included, I'm going to kill you all. And he could barely stand. And he'd been in there for 4 hours with all the tests that had been run. So you can imagine the noise that made in an almost empty pod of this metal chair slamming into the counter and then crashing to the floor, and it hit things on the pod. And so you can imagine everyone's, how that would make you feel. As soon as that chair hit the side of the bar and fell down into the floor, the 6 or 7 people left in the room had a variety of reactions. One nurse who was sitting in the pod where the chair hit just kept typing. She was documenting, and she never quit. She kind of glanced up, and she just kept typing. No response whatsoever. The nurse sitting across from her slinked down into her chair and then crawled under the counter and hid under the counter, and you could hear her crying. One provider stood up and beat his hands on the counter and began to make some threats in response. Another provider, who was already outside the pod, began to walk towards the door, and he was getting very big in his posture and basically saying, you're going to get in there and you're going to sit down and you're going to shut up or you're going to be arrested, and again, just that presence. One social worker began to approach the patient, walked past the provider and said, hey, why don't I get you a sandwich? And began to try to kind of bargain with him. What we did not know for about 45 seconds to a minute was that there was a student in one of the exam rooms on the other side of the pod who, with the door open, had seen all this happen and had slid back into the room and had called 911. And he was absolutely scared to death. He called 911, and I don't know exactly what he told the operator, but within a few minutes, we heard the sirens, and police officers were beginning to surround the building. Fortunately, one of the intake specialists who heard something go on, she stuck her head in, saw what was happening, and then when she heard the sirens, she went out and met the police and explained what was happening. At the end of the day, it turned out to be in the patient's best interest, I think, because in the midst of all that adrenaline, he collapsed. And when he was unconscious, he was taken by ambulance to the hospital, and he received the treatment that he needed, and he was back where he wanted to be within a few days, and he had a full recovery. But our team didn't recover for a long time because the providers who had responded sort of in force, many of the nurses began to sort of see them as bullies and felt that they had really bullied the patient, and they really took up an offense for the patient. And the nurse who kept typing, she really felt like everyone had exaggerated the whole thing. She felt like everyone had blown it out of proportion. The nurse who was crying down underneath the counter, she began to think, if something really happens here, no one here knows what to do. My life was just in danger. And my best friend, the head nurse, my supervisor, she didn't even flinch. She wouldn't do anything to protect me, right? The social worker, the provider really felt that the social worker who had kind of pushed past and was trying to offer him lunch had disrespected him as the provider and as the head staff. So you can see how everyone in the room, this really caused people to look at each other with some mistrust. And it was a long time before we got to a place where we could talk about what happened and where we could talk about what was the ideal response without feelings being hurt and without people being defensive. So when we talk about safety and security, it's really important that we realize what a complex subject it is, because something that, just like we see in that story, something that maybe makes me very, very scared may not affect you at all, and vice versa. And so when we think about policies and procedures around safety and security, we know that the whole topic of safety and security adds to the stigma that people feel about people that are homeless, or people that use substances, or people with mental illness. So I've actually done this training in some settings where people said, this whole training is horrible, is not trauma informed, because we shouldn't even be talking about safety and security. Whereas others want to make safety and security policies around every aspect of your day and every workflow. So as we talk about this, we really have to take that into consideration, that safety is really in the eye of the beholder. What makes someone feel safe, what helps someone to feel secure, is very subjective. And so it's very important when we talk about this, and this is a brief training. What we're really going to do today is we're going to talk about what are the questions that we need to ask as we think about safety and security. What are the questions that I need to ask in my own heart, in my own mind? What are the questions that I need to ask with those that work immediately around me on my team? And what are the questions that we need to ask as an agency, as an organization, as a system? What I'm hoping today, in this very brief time that we have, is that you will leave with questions to ask, with tools to guide conversations to inform your own safety and security policies. So please feel free to put things in the chat. I am hoping we'll have a little time for questions and answers at the end. But I also, like Katie said, would hope that this would be a time where you're learning from each other. So feel free to fill up the chat with your own thoughts as we move forward. So what makes you feel safe? What makes you feel threatened? These are all important things to know. What sort of situations do I feel really afraid, even though I'm not actually in danger? That's really important to know. What are the situations where I feel defensive, where I feel offensive, right? And how can I mitigate some of that given the workforce that I'm in? What really defines reality versus just what we feel? What are the times when I feel very unsafe, but the reality is I'm safe? What defines safe, right? So those are all things that we need, that really form the foundation of our safety and security conversation, is knowing the answer to these things in our own heart and mind, with our team and with our organization. And you can see that even in this variety of responses, how people can differ, and how it's really important to have some self-awareness around this, I think, is huge. So one of the things that we talked a lot about when we did listening sessions around this was sort of this life cycle of safety and security policies and procedures. And of course, to satisfy the requirements of OSHA and government organizations and local organizations and funders, we all have policies and procedures around safety. But this is what we really found as we met with a variety of organizations, that every organization has policies and procedures around safety. But we find that for many organizations, those policies and procedures are sometimes very unrealistic. Sometimes policies and procedures are written by people or agencies that never engage your patients. So they're not written about reality. They represent the ideal. Sometimes they're just unrehearsed. No one knows the policies and procedures. Sometimes they're unknown completely. By unrehearsed, I mean, sometimes we have a policy procedure, we all know it, we can all quote it, but we don't know what it looks like in context. I understand this, I understand the rules, but in this situation, how would I apply it? So we're never doing role playing. We're never talking about how those really work in real life. And sometimes the policies and procedures are unchallenged. We talked to a lot of agencies where the intake specialists, the nurses, the CNAs, they all know that those policies and procedures are completely irrelevant and completely impractical. But they don't tell anyone. They don't feel like it's safe to tell anyone. And so they continue to disregard them, to kind of bend them, to ignore them. So as a result, when that's the case with policies and procedures, very often staff interpret those policies and procedures inconsistently. And you'll have some staff who apply them very rigidly, and you'll have some staff who don't apply them at all. And as a result, patients very often will begin to know, well, you know, if this staff member will let me smoke outside, right outside the front door, but if this staff member sees me, I better put it out, right? Or whatever the situation may be. With this staff member, I can kind of push the limits, and I can kind of give some pushback and tell them how I'm really feeling. But with this staff member, I better not. And so, so you begin to see this inconsistency, and very often that can cause friction in your team, where patients prefer certain providers. You can imagine, like the example that we gave, there can be a lot of friction there. But then very often, and this is the agencies that we've worked with the most closely, this is what happened. There was a crisis. We've worked with some agencies where a provider was physically assaulted, or even where a provider was killed, or where something horrible happened and they were sued. So something horrible happens in the area of safety and security. And then of course, all the red lights go off, right? Our policies and procedures don't work. And staff begin to blame each other, and maybe the community will also blame staff, and all the horrible things that can happen when you have a disaster, right? And I want to be really clear here that horrible things can happen even when you have really good policies and procedures. So it would be a mistake to sit through this training and to think in your mind about the, you know, maybe really sad, maybe really, really bad things that have happened in your health center around safety and security, and then look for ways who's to blame, and we must have done something wrong. And I've worked with programs that had excellent policies and procedures, and policies and procedures don't necessarily mean that nothing unexpected, or even that nothing really horrible won't happen. But this is an example of one way that policies and procedures are sometimes formed as coming out of that crisis, and then we can kind of cycle back around. So very often, almost always, when there's been some kind of crisis, there is an outcry around for new policies and procedures. And sometimes there's an outcry for more aggressive security. And sometimes some people will say, no, we need to have a super trauma-informed response and have less security. But very often we'll see this tension after a crisis. But one way or the other, almost always after a crisis, new policy, or the threat of a crisis, new policies and procedures are written and they're adopted. But then again, if they're not rehearsed, if they're not known, if they're not challenged, if they're not discussed. So an interesting thing to think about would be, what do we do with policies and procedures? Something that we want to think about, and when we think about safety and security, is we want to think about external and internal risk factors. Our external risk factors would involve the environment around our health center. What is our community like? How does the community feel about our health center, right? We think about this a lot with mobile health, but do our neighbors love us? Do they hate us? What does that change? What does our parking lot look like? When we think about from the time a patient leaves their shelter or their camp or wherever they slept until they walk into our front door, what challenges do they face? What is their state of mind What is the level of anxiety and danger and threat and challenges that they face before they ever get to us for the average patient? What is our patient culture like? Do most of our patients come from the same place and speak the same language, and there's a sort of a shared culture? Or do we have patients who are enemies naturally by culture? I worked at a shelter where we had a lot of gang violence, and there were people staying at our shelter who outside of our shelter were really literally at war with each other. We saw that at the health center that I mentioned, where people were coming as refugees from both sides of conflicts. So thinking through all of that and asking those questions. And then what do we do with items that people bring into the clinic? And we're going to talk some more about that at the end. And then we want to talk about internal risk factors. What are the internal risk factors? And these are some questions that we can use to kind of evaluate that. We did this, we've done this at a couple of health centers that I've worked with, and thought through, okay, if we have a stack of incident reports from this year of all the different times when someone was threatened or someone was aggressive, or what do they have in common? I was working with a health center, and we did that. We went through all the incident reports, and we found that most of the acts of aggression, or where someone was frustrated, whether it was staff or patients, most of those happened in two places. One was the pharmacy and one was the lab. And so we stopped and we looked at that and realized, okay, at our pharmacy, a lot of patients were waiting for a long time at the pharmacy. They had to stand. There wasn't very much room to wait. And then when they got up, we found that a lot of our patients were expecting a different medication than what they got. Sometimes it was because the name of a generic, sometimes it was because of poor communication, but that was resulting in a lot of frustration. We discovered with our lab much of the same thing, that patients often had to wait. And while they were waiting at the lab, they could hear often young children or others right inside the lab, sometimes crying, sometimes screaming because they were having lab work done. And that was creating a lot of anxiety. And that sometimes people were having to get lab work done they weren't expecting. And we also discovered a few key staff members whose names showed up in those reports over and over. Sometimes we think, you know what? We're serving a high-risk population. We have limited resources. We have workforce issues. We're doing the best we can. And so, yeah, people are going to get angry and people are going to get disappointed. And there is truth in that. But sometimes we just come to work and we expect a certain level of aggression, frustration, disappointment. And so we don't put a lot of effort in evaluating, well, wait a minute, are there things that we can do about this? Are there common denominators? In reality, we were thinking, well, yeah, people are at a health center where the language that they speak is not their primary language spoken, and many of them are hungry, and many of them are dehydrated, and so we just assume, so they are angry. But we found that when we did a little research, the reality was there were factors that we were contributing to frustration, and there were issues that could be solved. And they were solved, and we saw a decrease in incidences. So how are you regularly assessing those reports? Hopefully you do a debrief, but are you looking for trends and then trying to come up with ways to address those? Often what we find with safety and security in health centers is there's no one whose job is to step back and go, wait a minute, what's happening here? Where do patients congregate? Where do patients wait, and in what conditions? Where do patients feel most fearful and ignored? There's no one who has the capacity in their job description to ask these questions, and that teams aren't asking these questions together. So part of the question, even in informing the conversation, is who has this conversation in your organization? Who does these kinds of evaluations? And again, these are questions to ask yourself and your team and your agency. In my work, when I look at my workflow, where do people, staff or patients, where are people normally aggravated with me? Where am I normally aggravated? When do I find myself getting frustrated or saying something that I wish I hadn't said, or I'm feeling hot in my temper? What are the circumstances? Where am I when that's usually happening? What time of day is it when that's usually happening? All of these can be really good questions to ask and simple questions that can make a difference in the safety and security culture of your organization. What are the most dangerous places in your organization? And the way we would, these are some of the adjectives that we would use to identify those places. Again, I'm thinking about that in my workplace, my office, the exam rooms I go in, as well as my team and the whole organization. But when I think about our workplace, whether that's street outreach or a brick and mortar building or a mobile unit, what are the most dangerous places? What are the places where staff are most isolated? Where the security cameras can't see me, where no one else can hear me, where I can't motion to anyone, and there's no landline phone. What are the places that are most crowded, where people are naturally kind of touching and no one has any personal space? What are the places, like we identified with the lab and the pharmacy, where people are most likely to feel stress? They don't feel like they have any control. They don't feel like they can make choices. They feel like they're being forced to wait or forced to hurry, where they're not getting what they want. Even if that's not something you can give, what are those places? Where there's low visibility, where there's no or few exits, limited and or untrained staff. And so we may be looking at actual places and also times in the schedule. This was a big issue that we looked at when I worked in shelter, was we realized that at nights and on the weekends, we had fewer staff and we had untrained staff. And so we had a lot of unfortunate things happen during those times. So that's an important part to look at. Where there are hard surfaces. There are places in your organization where if someone just gets a little agitated and just pushes someone, they can fall onto a sofa, or they can fall onto a sink, or hard instruments or something that's flammable. So what are those places where if something gets out of control here, it's more likely to be dangerous? And then thinking through, when I'm in one of those places, what can I do to mitigate that? So if I sense that I'm beginning to feel agitated and out of control and frustrated, or I sense that the patient I'm working with is, or the staff member I'm working with is, what are the places that I really need to be aware? While this is a place where if you're even just moving your arms around and you're animated, it's dangerous. Whereas if we step outside, it's not. So constantly being aware of that, or even just taking some time in the course of your work where you're aware of that and where you think about that as a team. What are the safest places? What are the brightest, easiest to get out of? Lots of windows, lots of people around, soft things all around, nothing sharp, nothing flammable. What are those places? And how can we have a plan to move toward those places when we sense that, if possible, when we sense that a situation could be tense or could potentially be dangerous? What are the least secure portions of my day or my routine from the time I pull into the parking lot until I leave at night? If something in my work area, if I suddenly felt unsafe, if I suddenly felt threatened, who would I ask for help? And I need to think through this in every part of my day. If I was here, if I was doing this, and something happened that made me feel unsafe, who would I call and how would I do that? What exactly would that look like? What would that process look like? Where would I go in the event of a crisis? How would I get there? And again, looking through every part of my day and thinking through these questions as a team. How would we support each other? What are the times of day where my teammate is vulnerable? What are the things where I need to know that during this, when he's doing this, he doesn't feel very safe and he may reach out and ask for help? And how will I know that he needs help and what will I do in response? These are just really simple, easy questions that can really enhance a culture of safety and security. And also where your staff knows we have time to ask these questions. We have time to process this together, right? It's very important. So again, thinking about this as a team, how do we identify threats to personal security, team security, guest or patient security? If I feel unsafe, how can I say that? How do we talk about that? How do patients report that? Who does that information go to? if I sort of do the little assessment that we just discussed, and I determine, at this patient or this time of the day, I don't feel safe. And that makes me respond a certain way. And then then they respond a certain way. How can I have that conversation, and who can I have that conversation with? If someone, like the example we gave at the beginning, if I really deep down inside feel like my supervisor is not going to do nothing, my supervisor is fearless and they will never feel unsafe. And that makes me feel really vulnerable. How could I have that conversation? Understanding that team dynamic is really, really important. So again, something else to kind of talk through. As we mentioned before, there's a real need for consistency here. And it's consistency in this that does help everyone to feel safe. Some people at your health centers come to work every day. They took the job and they believed, at this job, I'm occasionally going to be screamed at. I'm occasionally going to be threatened. Some of them took the job because of that, right? There's a little bit of an adrenaline rush. There's a little bit of a sense of adventure. There's a little bit of this idea of I'm helping people in a high-risk environment. Some people took the job and deep in their heart thought, well, no one's going to disrespect me. No matter what situation someone's in, they should still speak respectfully to me. And a lot of us draw that line in different places of what is that line of, wow, you can't do that, right? And the reality is that we all draw that line in different places. And so it's very important that you as an individual know where that line is for you, and that as an agency, you talk about where is that line? How will we allow our staff to be treated? But at this, so what should your staff believe is normative or is okay is really important to think about. And it's important for you to know, as administration, as leaders in your organization. What do you expect the culture to be like in your organization? I've worked in organizations where it was understood, where if I'd gone to my supervisor and said, hey, someone used 3 curse words today when they talked to me, my supervisor would go, yeah, so what? And I've worked in other organizations where if I went and said the same thing, my supervisor would be like, well, we need to have a conversation with them. We need to talk about what our culture is like here. So that's important that you all have a clear understanding of what the culture is like. And that's for you to determine, but it is for you to determine, right? Otherwise, there will be a lot of inconsistency around that. So what are the boundaries in your organization? When do we call it? So after that example that I gave at the beginning with the patient who threw the chair, immediately after that, there were some staff members who said very plainly, he's never walking in this door again, right? He is not welcome here. There were other staff members who said, no, next time he comes, we'll have these trauma-informed. We need to go get him and we need to bring him in more and we need to have trauma-informed principals, So who has the right to say, we're not seeing that patient anymore? Who has the right to say, you're not going to be able, you're going to have to leave for today, and then decide whether or not they can come back and when they can come back? Is there any time when you would tell a patient they can't come back? Who has the right to say about another staff member, you're going to have to go home today? What you just did was unacceptable. Where's that line for staff? Where's that line for patients? Who can call it is really important to know. And your staff need to know that. I have had staff who just very suddenly said to an angry patient, get out and never come back. And we're like, whoa, you can't say that, right? And then I have had staff who tolerated even physical aggression from a patient and didn't want to ask them to leave. So where is that line for you? How will others, my supervisor, my team members, respond to me if I tell them I don't feel safe? That's we have a whole training around psychological safety, so it's a much bigger topic. But if I say, I don't feel safe here, boy, that really bothered me. That shook me up. Will I get in trouble? Will I need to take will I be asked to go to counseling? Will I be given the number for our EAP? Will I be suspended? Will I be offered supportive services? Will I be ignored. What is your policy around that is really a huge part of safety and security, because very often, I want to say always, but very, very often at least, we will engage a health center where something has happened. And almost always there will be a staff member who will say, I was always worried about that client. I was always afraid that client was going to do something like this. But they didn't say anything. Or they did say something and they were ignored. And so even with and then sometimes there are others that were like, of course, maybe weekly or every day we encounter staff who just don't like certain patients, who don't feel safe around patients, and it's more based on bias. And these are difficult conversations. These are difficult assessments for me to conduct in my own heart and mind. Like, why don't I like this person? Right? So how do we think about this? How do we talk about this is really, really important. But the fact is, if your staff feels like there is no room to say that I felt threatened or that I don't feel safe, then they will not speak up when there are legitimate safety issues. I think that's really clear, right? So how do we build trust in one another? How do we encourage the reality that we want this to be a safe and secure place, and yet we're also doing work that can be dangerous, and yet we also may have bias and stigma against some of the people we're serving. These are all thinking through how we're going to talk about this in your culture is really a huge part of safety and security. Something that there's a lot of debate about is, do we document when someone has a history of aggression or when someone has done something aggressive? And so we've had conversations back and forth. This is certainly something to talk about in your organization. A lot of agencies have said that they would have, some agencies just in their electronic health record, if someone has done something aggressive, they've threatened someone, they've laid their hands on someone, they've destroyed something, then there'll be a flag. And they're still going to allow them to seek services there. There'll be a flag. And as soon as that patient checks in, the flag goes up on EHR and we all see it. And certainly that may be helpful, but even if that is your policy, it would still be helpful to think through, why do we do that? Do we do that because we think this person is likely to do that again, because we want to offer them special support? What special support are we willing to offer? I've worked with a health center not long ago. They had a patient that if he had to wait in the waiting room, he would get very, very agitated. And after just a few minutes, he would end up throwing down his coffee, pushing over a chair. But if he could come straight in from the street and go straight back to the exam room, the visit was flawless and there was no issue at all. So it started all this conversation. Do some patients not have to wait? Do some patients get special, should the flag that goes off on his electronic health record be a flag that says, doesn't need to wait in the waiting room, right? Or do we say, nope, everyone has to wait in the waiting room, and if you can't wait in the waiting room, then you're not able to receive services here. And of course, we could apply that in 1,000 different ways. So if you do decide to flag a guest, why do you do that? Because certainly that can be a way of encouraging assumptions about a patient and creating anxiety in staff too. So how do you do that? Using a strengths-based approach. What works with this patient? What does not? And again, this is something you have to decide. I've worked with health centers where a certain patient really didn't like a certain nurse or a certain provider. And so some health centers would say, oh, well, you either work with that provider or you don't receive services here. And others would have a note on their electronic health record that says, don't use this nurse and this patient, don't ever see each other. So what are you willing to do? And if you are willing to make some adjustments, who has the capacity to figure out how that's noted and how that's applied in a way that is still equitable? Noting trends is kind of what we're talking about there. If a patient really struggles and tends to get frustrated or defensive or aggressive, are there trends there? We've had some patients who every time they came in sober, they were more likely to be aggressive, or every time they came under the influence of substances, they were more likely to be aggressive. So what are the trends that we see, and how can we brainstorm with the patient to help them be successful? Are there conversations that we can have to help them be successful? And then communication between staff in administration. There's so many health centers, so many shelters too that we've worked with, where someone comes in, they have their intake, they sit in the waiting room, they go to the exam room, they're met by a nurse, they're met by a provider, they go to the lab, they meet with the social worker, they go to checkout, and at checkout or somewhere in that process, they just have a meltdown, and it's, there's threats and there's aggressive behavior, and it's very, very unpleasant for everyone. And the intake specialist says, yeah, I could tell they were mad. I could tell they were having a bad day. And the nurse says, yeah, he was really mad when I saw him too. And if you track back, everyone who saw that patient will say, yeah, I could tell he was having a bad day. But that never got communicated. And no one stopped to say, wait, he's having a bad day? Instead of pushing him on to the next person, who stops and says, hey, you seem like you're getting agitated? Who takes who doesn't do just their job and check off things on their clipboard, but actually addresses that, is a huge success step that we see with health centers that do this really well. So I want to close with this. This is the one item that we get the most technical assistance requests around. So so it's a little random, but I think because we get more technical assistance requests around this. We've had this come up more in committees and in network meetings. This is something we're almost always asked. So I think there's value in just taking a minute to talk about that. And that is, what do we do with contraband items that come into the health center? Whether that's a weapon, like something that was intended to be a weapon, or something that could be a weapon, just a sharp object, maybe something that's, the patient uses for cooking, or some sort of farm implement, something like that, or it's something like drug paraphernalia or drugs, or what do we do when someone comes in with something that that is in some ways contraband. And so what I've listed here are what the different ways that we've seen health centers that are thoughtful about this answer the question. I will be honest, I've worked with health centers that answered this question one way, and then they had someone hurt, and they changed it and answered a different way. And most of those health centers that we work with that have a stronger response, it's because something happened that really scared them, or where someone was really hurt. But these are the different answers that we see. Again, so discussion points for your organization. Some organizations completely ignore it. We see you walk in and you have a machete on your belt. You bring in, it's your personal property. We don't say anything about anything, right? And that's their policy. Again, what's important here is to have a policy. I'm not going to tell you which policy to have, but it is important to have a policy. If something happens, if someone gets hurt, you want to be able to say to the community, to your funders, to your board, to the people who were hurt, yes, we had a policy. This is the policy we had, and this is what informed that policy, and we're going to re-examine that policy. But you don't want to say, well, yeah, this never came up, so we never, right? You want to be intentional about this. So number one, some health centers ignore it. Some health centers, and this is something that's growing, and so we're seeing some different iterations of this, will develop a safe storage place. Some health centers are doing lockers. They may be outside, they may be in the lobby area, but a patient comes in, very much like you would maybe do at the airport. They pick a locker, they put anything they want in that locker, they close the locker. What's in the locker is never seen by health center staff. No one asks what's in there. They go and they do what they need to do for their health, and they come back at the end and they pull the stuff out of the locker. Some people are doing lockers. I've seen mobile health units where there was just a bag or a box that patients put their stuff in. It didn't lock or anything. It was just a safe place where at least those things were not accessible to the patient while they were receiving services. Now, there are issues here, but that as far as where do you put that? Does everyone see what they put in there? Does it become this place where people are very vulnerable because everyone sees what they put in there? Do you have security? What happens if people forget their items and you go back and there's an item in there that you don't feel comfortable touching? But that's one method. Another method is where guests with items visible on campus are asked to dispose of items or store elsewhere. So in other words, it's kind of a don't ask, don't tell. But if we see an item that's contraband, and of course the contraband items would have to be listed somewhere, then we will tell you you're going to have, that can't come in here. And it's just that simple. You can't bring that in here. If you have to keep that on your person, you can't receive services today. Another method is where guests are searched and their belongings are searched every time, sometimes with a metal detector, sometimes with the metal detector that they walk through or that they scan their belongings. And some health centers choose to search the guest, but not their belongings. So in other words, the guest is sort of searched maybe with a wand or asked to empty their pockets, things like that, but their belongings are not. So no bags are unzipped, anything like that. In the event that contraband items are discovered, some agencies will destroy them. So if you walk in and we find that you have a contraband item, we're going to confiscate that, or we're going to ask you to put it in this bin and it will be destroyed. Some will give the items to authorities, but anonymously. So they'll have a pickup time where authorities will come and pick up any weapons or drugs. And then some agencies will say that contraband item and the guest or the guest information will be shared with authorities. And so, of course, whatever policy you adopt, it's very important that you make your patients aware of that. What are the contraband items and what do you intend to do? It's very important to always be very transparent. And these are policies, again, that would be developed, with a lot of conversation with your board. This is not a policy that one person should say, well, this is what we're going to do. This should be something that everyone understands the policy and that stakeholders are identified. All right, so that was a little bit of a whirlwind look at safety and security, and again, really just some of what are the things we need to talk about? What are the things that we need to think about? So what does that make you think of? What comes to mind for you? What questions do you have? Obviously, lots more that could be said about this, but what comes to mind for you as we've talked today? And I cannot see the chat, so if there are things in the chat, please feel free to read that too.
Yeah, I'll read them if I get any. But I saw earlier at the beginning, Janice mentioned that she wanted to talk about recent safety issues with their street team and other satellite locations. So I guess my question to you was, like the health centers that you have worked with, have any of them had street teams? And like, what are some other things you need to consider when you have satellite locations with street teams out about?
Yeah, we have done a lot of safety and security work with mobile health units and some with street outreach units too. And of course, that is a totally different ball game. Some health centers will develop policies and procedures around safety and security and try to apply those uniformly for the brick and mortar building, street outreach, and mobile health. And the reality is a lot of safety and security has to do with context. So there's something, if I'm very angry and I'm kind of very animated and my gestures are big and my language is big and I'm loud, there's one way that comes across if we're standing in a field. And there's another way that comes across if I'm in a waiting room with families and people all around me, right? So I think we do have to apply safety and security principles based on context, and that's really important to do. That team dynamic is very, very important when you're doing street outreach. That if I suddenly don't feel safe, when we talk to street outreach workers, we talk a lot about just that feeling in your gut that, wait a minute, this isn't okay. And how do you communicate to each other? I don't feel good about this. And that's really important if you are in an isolated location. And how you communicate that to each other. So important that outreach workers know where they are. This is one of the biggest things we see with outreach workers, that I follow a path down into a field, and especially in rural healthcare, and I suddenly realize I have no cell phone service. If I did call 911, I have no idea where I am, right? And so what are you going to do about that? How do you keep your location? What policies do you have around having a policy, and understanding why you have a policy around whether or not someone can go off by themselves or they have to be with other people, whether or not you can put someone in your private vehicle, what items you take with you and what you don't are all really, really important with street outreach, I think. And those are things that we talk a lot about, but I think understanding the team dynamic and what's allowed and what's not, and being committed to that, I think is really, really important with street outreach. Understanding how you present. When you walk up to someone, to a group of 3 or 4 tents, who do people think is walking up? You know, sometimes we walk up and we've got maybe kind of a uniform and a big backpack, and so even how our policies around, this is what I'm going to say when I walk up, that boundary line of when we back out. Sometimes people are so committed to, we have to give these vaccines today. We won't be back here, you know, for 6 more months. We have to, and a sense of urgency will very often cause people to make decisions that violate their own sense of safety and security. So anytime I have this feeling in myself, this must be done. I must see this patient no matter what. We have to finish this procedure. It's got to be today. Any feelings that I have like that, which very often accompanies street medicine, we have to be really careful. I should always be willing to say, we're going to have to back out today. And we'll send in more referrals, or we'll send in more help, or we'll figure out something else, but I'm going to have to leave. Very often we're not willing to do that. And so that can really cause us to compromise our own safety, the safety of our patients, the safety of our team members. So those are all important things that are unique for safety and security for street outreach, I think.
Yeah, yeah. Looks like Chris had a question asking if there are any resources, examples, or templates available for policies on contraband and patient searches.
I don't have a lot of great, you know what, if you'll email me, I'll see what I do have. You'll also get the slides which show the examples. And so a lot of different agencies will differently write out the policies and procedures based on what we just said. It's really important that you create a policy and procedure around contraband items that aligns with your mission, that your staff buys into. The reason why we did that slide, that's a hard policy to create because people can have such strong feelings about it. But email me and I can see if I can. Sometimes we have other agencies that we work with that are happy to share those. I don't think I have any on file that are recent at all, and I would need to ask their permission before I shared them again, just in case they've updated them. But I'm happy to investigate that for sure.